First of all, a huge welcome to the University of Leeds. For those of you who don't know me, my name is Carl Thompson. I'm a Professor of Applied Health here in the University of Leeds, the School of Healthcare to be exact. As I said, it's a huge pleasure to welcome most of you who've turned up tonight. Not everyone, I don't like you all, but no, it's a huge pleasure. For those of you who haven't done the Shed Talk series before, the clue is in the name. It's the School of Healthcare Education Debate. You're in a place of education and we want debate. So the rules are challenge, it's a safe space, we take any sorts of questions. The researchers are here to bare their souls in front of you and you're in for a really stimulating period of time coming up. And we've got some great speakers around a really crucial topic, both for the City of Leeds and nationally. It's the first national study of its kind, which you're going to hear all about over the next sort of hour and a half, 2 hours. We're also blessed by a fantastic panel here from a range of people in the industries involved in providing social care, and we're thankful for them coming, and you'll be hearing more from them later on. And we're also blessed at the University of Leeds by having a Vice-Chancellor who's actually interested in health and social care, but not just interested, but actually uniquely qualified as a former Chief Executive of the NHS, and Sir Alan is going to be steering us through the next couple of hours as well, and making sure that our mission of educating and debating around some of the issues raised tonight are brought to the fore, and I've seen him in action and I know how good he is at doing it, so I'm confident that will definitely happen. The School of Healthcare is all about partnership, and we are both honoured and pleased to be working in partnership with Bupa. But it's a partnership that's existed between us and Bupa for the last couple of years, and it's been a very productive and growing partnership, and we're very pleased to welcome them here, and we're thanking them for co-sponsoring tonight as well. As I say, we are a School of Healthcare. We pride ourselves on partnership. Quite literally, the partnerships generate our research. So our research is all about making a difference. It's about answering the questions that are important to the industries that we work with, both the NHS and health and social care, and you're going to be hearing all about some of those uncertainties in the next couple of hours. So I'm going to stop there. If you've got phones and things like that, we are going to be tweeting throughout the night, and there's the hashtags there throughout the night, the next couple of hours, unless it goes really well. Feel free to tweet, but don't feel free to answer your phones. So if you've got phones, put them onto silent. That would be fantastic. Beyond that, I'm going to hand over now to Professor Karen Spilsbury, who's going to tell you all about the STARK study and set the scene with some of the findings. But if I don't speak to you again, I'll see you later in the networking event. But have a fantastic night, and I hope that it's stimulating and informative in equal measure. So Karen, over to you.
Thank you. So is it evening or afternoon? Good evening, good afternoon. I'd also just like to extend my thanks for you attending this lecture this evening. This is the second lecture that we've done, and this is on the back of the demand. If you were here at the launch in 2017, it was, but we want to know what you found. So this is your opportunity to hear a bit more about this. So I would like to acknowledge my co-presenters and panel as well that I'm sharing the stage with this evening. Thank you so much for joining us and supporting the event. My introduction is going to be very deliberately brief because I really want to give the floor to Kirsty and Andy. But what I would like to do is set the scene, try and orientate you to why is this such an important focus for a study before we go on to share with you some of our interim findings. So because we are funded by the NIHR, I just want to acknowledge their support for this research at the beginning, and also to state that obviously what we talk about tonight, these are our views, the views of the authors, and not necessarily those of our funder or the Department of Health. So now Andy and Kirsty have permission to say whatever they like. We've got that out of the way. Carl mentioned partnership. I think this project really highlights why partnership is so important, and I think without partnership we would not have got funding for this study. So just acknowledging that really about the range of academic departments involved in this study, and also the sector organisations that have supported this work from pre-application stage, offering support for the work. As I said, without that, I don't think it would be have been successfully funded, and I don't think we'd be all sat here now today. So it really is fantastic. What this partnership brings is a skill set that's diverse to actually deliver on the research. But I think what's really important, and why it's so important we're sharing findings at an interim stage, is that you also get an opportunity to partner in this and help us make sure that the findings are sector relevant, that they will have an importance for people who are providing services, but also for people in receipt of that care, residents and relatives. So thank you for being with us. In a room like this, I probably don't need to spend too long talking about why it's important, so I just want to say a few key things so that we're really in the zone when you start to hear from Andy and Kirsty. We know that the care home sector has more beds than the NHS, and it's caring for a predominantly older population with really complex needs. And how to ensure that the quality of the care delivered to residents and the relatives is a societal priority, something that we really have to get right, and something that the sector are really keen to get right as well. And the workforce is really key to making that happen. Having the right workforce of the right size, with the right skill set, the right values and behaviours, that's what's going to promote quality. But why did we apply for the funds for this study? It may surprise you that actually we don't know anything about that. There have been no studies to date in the UK to actually address this issue. So our aim is really simple. It's to plug that gap. We don't know anything about how the UK care home workforce influences quality, what staffing level and mix would best meet resident needs, how to promote the use of that available and valuable human resource, how do we use it most effectively to benefit residents in care, and how do we promote cost-effective use of the resource to benefit residents. So our aim is simple as that. It sounds simple, doesn't it? And yet, we talk about this relationship between staffing and quality. And so I think I would like to acknowledge that what we're doing is actually very ambitious. I think when we talk about quality, what we recognise is that there can be very many definitions of quality depending on who you are. If you're a policymaker, you might have a very different definition to someone who's a resident or who has a loved one living in a care home. So what our study plans to do is actually address quality from a range of different angles. So we're seeking to explore and understand and explain quality, drawing on those range of perspectives, and we're doing that through a series of linked work packages. You'll be relieved I'm not going to go into these in detail. I've put this up purposefully just to say that this evening what we're going to be talking about are findings from Work Package 1, which is a review of the literature to understand more about the workforce and how they affect quality, and Work Packages 2 and 3, which have used large data sets to model those relationships. And we're coming on to Work Package 4 and 5 in the next few months. So actually this lecture comes at a really key point, and that I emphasise again, Carl saying this is about debate and challenge, because some of the questions you ask us might really guide some of the future work we do. So I'd like to hand on now to Kirsty, and I look forward to engaging in that discussion with you in about 45 minutes.
Hello, can everyone hear me okay with the mic? So during my presentation I'm going to be focused on Work Package 1, describing the care home workforce. Sorry, can everyone hear me okay, because it sounds a bit...
This one any better, Kirsty? Try this one. Might put it there rather than on there.
Is that better? Is that better?
Kirsty, Jesus. There we go.
So as part of this work package, we're reviewing the literature to try and understand a bit more about how staffing influences quality. And other reviews have looked at the relationship before by combining large data sets. And these reviews have provided us with a snapshot of evidence about how staffing inputs such as numbers, mix, deployment of staff, how they impact clinical outcomes such as falls, pressure ulcers, use of physical restraints, those types of clinical outcomes. And in our review, we want to build on the findings. So, for example, Karen mentioned in her presentation that quality means different things to different people. So we realise that the studies in these reviews have quite a narrow focus on quality. So we want to look at some other aspects of quality. So quality of life, for example. And we found that findings from these reviews have been quite inconsistent. So staffing numbers and mixed have influenced quality in some contexts, but not others. So we want to try and address some of those limitations. And when we've looked at the studies within these reviews, we've noticed that they don't use theory to try and explain their findings. And theory is quite important because it helps us make links from one, so why we can answer the question of why staffing influences quality, which is something that the studies in this review haven't done to date. So what we're doing is we're doing a realist review to try and address some of these limitations. So rather than looking at effectiveness and whether staffing influences quality, we want to try and, we're not looking for what works, but what works for whom and in what circumstances, to try and explain why. And we recognise that staffing is a complex intervention with many components, and it's likely to be reliant on organisational factors, individual factors and team factors. So we want to answer this through opening the black box of theory, and we're doing this by looking at some organisational factors and individual factors and team factors. So with a realist review, we zigzag between ideas and evidence. So one of the things that we've been doing is, so we've looked at some of the early ideas from the literature reviews we've just discussed, and what we've done is set up some stakeholder groups with residents and relatives and care home staff, and we've asked them what does quality mean to you, because it's a vast area and we wanted some direction. And our stakeholder groups have helped steer the review by telling us what's important to them. And they told us that it's not about qualifications, but it's what staff do and how they make us feel. So this directed us towards the behaviours. So we think that the behaviours of staff are important for driving quality. So to help direct us even further, because it's quite a vast literature, we drew on a known framework to help frame our review called the COM-B model. And it's been used in different healthcare contexts, and it hasn't ever been used in the care home context before. And the idea, I won't dwell on it too much, but the idea is the capabilities, the opportunities and the motivations associated with staffing will trigger behaviours that promotes quality. So to translate in our review, if a staff member feels capable, so they've got the knowledge and the skills, they've got the knowledge and the skills to be able to behave in a way that promotes quality. If they've got the physical skills, so they're able to hoist somebody, they've got the psychological skills, then they're more likely to behave in a way that promotes quality. And if they've got the opportunity to do that, so for example, staffing levels, they've got the time within their day to do that. And if they feel motivated, so if they want to do it, so if the care home member of staff feels that they really want to do it and they've got that caring nature, then they're more likely to behave in a way that promotes quality. So we're using that framework as a lens to help us navigate through the literature and try and come up with some behaviours that promote quality. And I say we're zigzagging between ideas and evidence, so we're using that framework and then we're going back to our stakeholder groups to do some sense checking, just to make sure that what we're finding makes sense to residents and relatives and care home managers, because we want our findings to have application in practice. So I said earlier on that we recognise that staffing is a complex thing and it's reliant on organisational and individual factors. So we've identified 3 key mechanisms that we think drive individual behaviours. And The first one is a commitment to resident-focused philosophy of care. So the literature is telling us that if a staff member feels that if they feel committed to resident sense of focused care, so for example, they feel an obligation towards a resident and they feel that they want to get to know them, then that translates into behaviours that promote quality. So they get to know their resident, they get to know things about them. The second one is reciprocity among teams. And if there is reciprocity among teams, and I'll come back to this one later, then that translates into behaviours that promote quality in terms of that teams share information with each other and they draw on each other's skills and knowledge. And finally, the third key mechanism that we've identified is staff who have a mandate to act autonomously and independently to meet residents' needs. So if staff feel like they're able to do this, then I believe it leads to behaviours that promote quality. So, for example, problem solving and decision making. So, in this Bupa lecture, I'm just going to focus on one of the mechanisms, just to try and give you a bit of a flavour about what we've found. So, what do we mean by reciprocity? So, the literature uses words such as trust, mutual respect, and a value for each other's contributions, and asking and giving help. So, for example, staff members who pitch in to help each other out, who show their appreciation, they give praise to each other and say thank you, and they listen and let people vent at difficult times. These are terms that we find in the literature that we've termed under reciprocity among teams. So why is it important? So if there are reciprocity among teams, then it leads to the behaviours such as sharing information and drawing on each other's expertise. So for example, by sharing information, we found evidence in the literature, so staff listening into each other, explaining things, verifying what they mean and clarifying information, asking each other questions and comparing experiences. So these are the things that occur when reciprocity is present among teams. And secondly, the mix of staff in a caring team is different. So everyone's got a different role. They all come with their own knowledge and skill sets. So if there's reciprocity among teams, then staff are more able to draw on each other's experience and learn from each other at various different levels in the organisation. And we think that diversity, having the cognitive diversity, helps with sharing ideas and sharing knowledge and how best to deliver care. So this means that staff are able to brainstorm and problem solve, make suggestions and suggest alternative things and make sense of things that they wouldn't be able to do if they weren't able to rely on each other's expertise. So I've highlighted a couple of quotes just to try and explain what we mean and try and give you examples. So in the first quote, two care assistants are talking to each other, and one care assistant was able to help a member of staff, a resident, and she shared the information with another member of staff, and then that led to a new behaviour because that other member of staff was able to help the next day. So this is an example of where sharing information led to a new behaviour. And in the second quote, a nursing assistant's talking to a nurse, and by working together and drawing on each other's skills and expertise, then they're able to work better together in a way that promotes quality. So they're just a couple of examples, just so you can get a flavour of what the things that we're finding. So I talked earlier about staffing being a complex intervention that was influenced by organisational and individual things. So in terms of reciprocity, there are things at an organisational level that need to be in place to trigger reciprocity among teams. So, for example, there might be more than this. We've just highlighted these four, and it's still a work in progress. But what the literature is telling us is that the size of teams are important. So, in small care homes with small teams, reciprocity was more readily described. And in larger care homes, reciprocity was also described, but when there were smaller teams, so staff teams were broken up into smaller units. So when there were smaller teams, staff had more engagement with each other. There were less people to communicate, so less chance of missed information. It was easy to stay focused and stay organised. So the size of the community or the size of the team was deemed important, and this can be addressed in larger care homes by creating smaller teams. What the literature hasn't told us so far is that the optimal size of the team, and this is something that we're going to go to look at other bodies of literature for, to try and help us to determine and see if we can get any clarity on that. So the stability of the team was also important for reciprocity. So the team needed to know each other well. There must be that familiarity within teams, so that reciprocity can be nurtured and so in large care homes, sometimes it was a problem because if the team was short-staffed, then staff had to go to other units to work, so it was difficult to achieve that consistency. And when staff were less familiar with each other, then the reciprocity was more difficult to achieve. Not impossible, but it's more difficult. So when stability of the teams, and so that means turnover and staff working within units regularly, then that helped with reciprocity. And leadership was also important. So leaders, and that's not necessarily the managers, but leaders create a shared sense of purpose, making staff feel valued and appreciated and involved in decision making. And staffing numbers, and so while staffing numbers alone don't tell us much, they are important for reciprocity, because you need to have a minimum number of staff to be able to have relationships with each other and share information and be able to draw on each other's expertise. So these are the things we've identified at an organisational level that influence the mechanism of reciprocity. And we've still got a bit more work to do with the other mechanisms. So I just wanted to give you a flavour of some of the interim findings that we've been able to identify so far. And this process is helping us refine our programme theory of the capabilities, the opportunities and the motivations of individual staff that influence behaviours. We think it's an important review. Karen mentioned it's the first time anyone's looked beyond a snapshot of big data sets to produce theoretically informed work. So, in a care home context. And one of the things that we're finding quite difficult is that some of the terms, such as quality, it's quite ill-defined in the literature. So it's good that we're working with our stakeholder groups because they can help to tell us what they think and how to progress. So our next steps are to describe the other mechanisms and a context, and continue to test the programme theory, because we don't think this is the end story, but we think that going back to other bodies of literature that aren't care home literature can help us reinforce or refute or change what we've got and promote the clarity of our message to care homes.
Thanks, Kirsty. Is my microphone working better than Kirsty's one? Any better? Yeah, that's better. It's getting the right balance. Okay. Hello, everybody. My name is Andy Charlwood. Probably unusually in this room, I'm not someone with a healthcare background. My background is in human resource management. But because of that, I'm really interested in relationships between workforce and performance generally, and using data to look at those questions. So really pleased to be part of this project. I'm going to talk to you today about work packages 2 and 3, which I will explain more in a minute. But this is also work with Will Fenton, who works for Skills for Care, and my colleague Danat Balazaid, who can't be here today because he's on his honeymoon. So, they did a lot of the number crunching, and I'm just kind of guiding the research and explaining what they've done to you today. So, really what we've done takes inspiration from an idea called the Learning Healthcare Organisation. And essentially, if you run a care home or any kind of organisation, if you were running it 30 years ago, you'd be writing lots of things down on bits of paper and putting those bits of paper in filing cabinets. And that's all terribly inefficient. So what's happened over the last 30 years is what people... this is a bit weird.
Will you take it off? Because actually I think we can hear you.
Yeah, okay. Can you hear me at the back? Great. If I start going down, okay. So, yeah, if you were running a care home or anything else, you were writing lots of things on bits of paper, putting them in filing cabinets, it's all terribly inefficient. So what's happened over the last 30 years, as information technology has improved, is that operations have become digitalised. So instead of writing things on bits of paper and putting them on filing cabinets, we click a button on a computer, we use a drop-down menu, and we're doing that not because we're interested in generating data, but because we're interested in doing things more efficiently. But a side effect of doing things more efficiently is that data is available to try and understand the organisation better. And the idea of the learning healthcare organisation is essentially how can we take all that that data that's being generated by people doing these routine activities and analyse it and interpret it in order to make better decisions about how we do things. Okay, and what work packages in 2 and 3 are, we've taken administrative data from 2 places. Firstly, Skills for Care maintains something called the National Minimum Data Set for Social Care, where different care home operators provide Skills for Care with data about their workforces and a little bit of data about their residents. And we've put that data together with information from CQC inspection judgments. So we've got all the CQC inspection judgments for all of the homes that are in the National Minimum Data Set, so we can look at how those 2 things relate to each other. The second source of administrative data comes from a care home operator that operates about 111 homes, and they've given us data for 3 years where they've got all of the kind of quality-related incidents that they recalled, and also details of their staffing, so how many hours are people working in those care homes. So we can look at the relationships. Now, that all sounds fantastic, doesn't it? If you're a geek like me, this is very exciting. But I have to, before I go any further, I have to offer some words of caution about some of the limitations of doing this. And probably the easiest way to do this is to give you a completely unrelated example. If you read a newspaper, or watch the news, or listen to the radio, every week you will see news stories about if you eat this or drink that, something might happen to your health as a result of doing that. Okay? So should you eat a balanced diet, as nutritionists traditionally recommend? Actually, if you eat a Mediterranean diet, you're going to have a less risk of heart attack, less risk of cancer. Brilliant. Should I drink a glass of red wine with my Mediterranean diet? Should I drink 2 glasses of red wine? If I drink 2 glasses of red wine after the reception tonight, will I get hungry and have a kebab on the way home? And what will that do to my risks of becoming ill in the future? And obviously, if you read this, it's all very confusing, isn't it? Because one study says this thing increases the risk of cancer, another study says this thing reduces the risk of getting cancer. And the reason why we see these confusing results when we look at these diet studies from observational data is because what we eat is correlated with lots of other things that also affect our health. So what we eat depends on our upbringing, the tastes that we formed when we were children, which will be partly related to our parents' income and social class. It will be related to our income now, what we can afford to eat. It will be related to our lifestyle, what do our friends and family like to eat, which again is related to things like social class. So unless we can really control for all of these things, which technically we call confounders, we're going to sometimes see conflicting results. And if one study is controlled for these confounders and another hasn't, they're going to come to different conclusions. The other thing about observational data is we're seeing what people actually do, and what people do is perhaps a small range of the things they could do. Okay? So if you look at diet in this country, it's generally very different to diets in other parts of the world. So if you're doing an observational study about diet in this country, you're going to see quite a limited range of possible diets. Certainly in any numbers. You might see small numbers of people with particular diets, but you're not going to see large numbers of people. And these things happen, the same issues are there with research using observational data about care homes. Okay? So we've got good data about staffing, we've got some data about residents, but obviously what the care needs of residents are going to dictate something about what's going on with staffing. Okay? If you have a care home that provides more, looks after more acutely ill residents, then they're probably going to have more staffing, but we don't necessarily know the residents are more acutely ill from the data that we have. And if we think about the care home operator that we're working with, they have a model for how they determine their staffing. They develop that model based on the professional judgment about the care needs of their residents. They're not going to say, okay, well, we're going to have fewer staff than we think we need, but also they're constrained by their resourcing and what what the market will pay, what funders will pay. So that constrains, they might think, well, ideally we'd like to have more nurses, but we can't afford to have more nurses. So we've got quite a narrow range of possible staffing outcomes that we see in this observational data. So just keep all that in mind as I go on to talk about results. So to kind of start to tell you or show you some of this stuff, this is from one of our kind of early bits of analysis, this graph here. And this is showing the relationship between care hours to occupied beds and medication errors. And immediately here you can see evidence of a confounding relationship, where actually what you would expect to happen, you might think, well, if we've got more staff, we're going to have fewer medication errors. But actually the line is going in the opposite direction. When you have more staff, you have more medication errors, and probably that's because when you have more staff, you have residents with more complex care needs who have more complicated medication regimes where it's easier to make mistakes, particularly if you're under pressure. The second thing about this graph, which is interesting, the red line is the average relationship between care hours and medication errors. And as academics, traditionally, we get very excited when we see these sorts of average relationships because we go, yeah, we found an average relationship that's statistically significant, woohoo, we can publish it in one of our academic journals and get brownie points from our colleagues for doing that sort of thing. But actually, if you're operating a care home, this sort of graph isn't telling you very much that's actually that useful because all of these blue dots are the different observations, and if you're one of those blue dots that's a long way from the red line, that average relationship isn't necessarily going to hold in your care home. And if the decision you're trying to make as a care home operator or as a care home manager is, should I employ more nurses in order to try and reduce medication errors, knowing about the average relationship is possibly not that informative. You want to try and understand what the relationship is likely to be in your care home or in the type of care home that you operate. And that doesn't necessarily come through from this type of regression analysis which we as academics have traditionally done and traditionally liked. Now, part of the reason why we do things like regression analysis as academics is because data is difficult and expensive to collect. So what we've traditionally done is when we do studies, we collect the minimum amount of data we need to find what we're looking for. When we're working with this type of observational data, we've got much bigger data sets. So what we've done is started to experiment with different methods developed from computer scientists for machine learning. So we're doing something called, and I'll explain this just so you know what I'm talking about, but I'll do this as untechnically and as quickly as possible so I don't lose you by talking about methods. We're doing something called a random forest analysis. And what that means is we take our data, we split it into two different data sets on a random basis. One of those data sets we use as a training data set where we develop a model. And once we develop that model, we then test it on the other half of the data to see whether it actually predicts what actually happens in the other half of the data. And the way we develop that model is by estimating lots and lots of different statistical models, 1,000 different statistical models, using predetermined decision rules to find the models that have the best predictive accuracy, and then we average the results of those models that have the best predictive accuracy. So we get to something, rather than that graph I just showed you, where you could be a long way from the average and it doesn't really tell you very much about what's going on, where we can predict with a much greater degree of accuracy how staffing relates to the care quality things that we're interested in. I've also put a Christmas card up here, and that is to remind me that I need to explain about the difference between accurate prediction and causality. So what this model does, it allows us to predict accurately what the CQC inspection score of a home is going to be or how many pressure ulcers it's going to have. But prediction is not the same as causality. So for example, if you didn't know the date of Christmas, you could use this sort of modelling to predict the date of Christmas by looking at things like how many Christmas cards get sent. But if you wanted to, if you thought Christmas in December is not particularly convenient, it'd be much nicer to have it in August when we've got the long school holidays. If you try to change the date of Christmas by sending 3 million Christmas cards, obviously it's not going to work. So Christmas cards are predictive of Christmas. They're not necessarily causing Christmas. And again, in a care home context, having more nursing hours might be predictive of something. It's not necessarily going to be causing something. So part of what, talking to you today as people who know a lot about care homes, to get at the first finding the results, I'm really interested in what you think of this, because there might be things that I'm sharing that are predicting something, But you would say, well, that's clearly not causal, something else is causal. And if you've got that, asking the question, put your hand up in the questions or come and talk to me afterwards and explain it to me, because that will help us tell a better story about what's going on here. Okay, so the first study based on the Skills for Care data. What we're interested in here is predicting CQC inspection judgments. Okay, and this is using the National Minimum Data Set for Social Care, which around about half of care and nursing homes provide data for. And CQC inspection judgments, very few homes are rated outstanding, 70% of homes are rated good, 20% are rated as requiring improvement, and just 2% are rated as inadequate. And generally, nursing homes, as opposed to care homes, or care homes with nursing, find it harder to get the highest scores and are more at risk of getting a lower score. And smaller homes tend to get the better scores, and larger homes are more at risk of getting the lower scores. So that's what we're predicting. Staffing things we've got in our model, the ratio of jobs to occupied beds, the percentage of care workers who are on 0 hours contracts, the average time in the current role for care workers in that care home, and whether the care home manager has been in place for 12 months prior to inspection. And then we've got some other contextual variables too, how big the home is, the percentage of residents with dementia, and excuse me, something about labour market conditions in the local authority, which I'll go on to talk about towards the end of the lecture. So this is just giving you a flavour of the results. So we're able to accurately predict the CQC inspection score in just under 92% of cases. So the model works in terms of being able to predict accurately. And it shows that actually staffing things are quite important in making that prediction. So experience of staff looks important, and generally, particularly the inadequate homes have less experienced staff. So this is suggesting more experienced staff leads to sort of better quality related outcomes. The jobs to bed ratio is also important for predicting the CQC rating, although not necessarily in the way that you might at first expect. So you might expect, based on what Kirsty was saying about reciprocity, that where you've got kind of more staff, you've got more time to build those reciprocal relationships, people are less busy, and that you might get better care. But actually, it's kind of the other way round. And again, if you think about that, that makes sense, because if you're a care home that requires improvement or is inadequate, you probably are finding it harder to get new residents to come and live in the home, because they are sort of sensing something's perhaps not quite right there, or they're looking at the CQC judgments. So you tend to have more staff for the residents you have. So there's a bit of reverse causality going on there. The takeaway from this slide then is that if we want to predict CQC scores, staffing seems to be involved, but we're not sure yet whether it's causal. And the problem with, or not the problem, but a limitation of this data set is we don't have particularly detailed measures of the resident characteristics. So how much of this is just that staffing is correlated with resident characteristics rather than being causal? So the care home operator data allows us to start looking at that in more detail. And the care home operator data has two kind of important characteristics from the perspective of this compared to the other data set. It's longitudinal. Okay, so we can look at change over time. We've got 3 years of data. And within that 3-year period, there is going to be variation over time in the number of staff that the care home has, because they're going to have vacancies. People are going to leave. People are going to be off sick. They're going to have gaps in their rotas. And there are going to be times where they are at full capacity with residents, and times where they have gaps where they don't have all beds occupied. So we can look at that variation over time in the supply of labour and the demands on care assistants and care staff's time in that home, to try and pick out whether that variation is associated with quality-related incidents. So the quality indicators here, we've got CQC inspection judgments again, because we want to see how this compares. But we've also got this routine data that the care home operator collects using a kind of computer system to record incidents, which is on a month-by-month basis. So whether there's a pressure ulcer developed in the home in any given month, number of falls. Obviously, falls aren't necessarily a measure of quality, because If you give residents a degree of autonomy and independence, there's a risk that they might fall. If you have dementia residents, particularly when dementia residents first move into a home, they're more likely to fall over because people haven't worked out exactly what their care needs are, and that takes time to work out. So falls aren't really a measure of quality, but they're in there just so we can compare it to falls that result in fractures. And then we have medication errors, and then we have complaints. The staffing measures we have in here, we have the average care hours per resident bed per month. We have the proportion of those care hours that are from senior care assistants and nurses compared to care assistants. And we also have the CQC well-led score when we're looking at the incidents, not when we're looking at the CQC inspection judgments. Clearly those two things are going to be closely related to each other. Contextual variables, we've got whether the number of available beds, the proportion that are occupied, admissions in the month, because again admissions are going to increase risks of things like falls while residents get to know the home and the home gets to know the residents. The percentage of residents who are self-funded. Again, if you have residents who are funded by local authority or CQC, they probably have more acute care needs, they may be less mobile, so that's going to affect some of the risks of some of these things happening as well. Percentage of residents with nursing needs, and the percentage of residents with a dementia bed. And again, we started to look at labour market conditions in the local authority in which the home is based. So the first thing we were interested in trying to understand a bit more about was the relationship between what the CQC says about quality and some of these data collected in the home. So the blue columns just kind of highlight the measures that seem to us to be related to CQC score. So generally, medication errors and complaints are both related to CQC inspection judgments. Outstanding homes have fewer medication errors, fewer complaints. Requires improvement homes have more medication errors and complaints. Inadequate homes seem to have less medication errors than requires improvement homes, but that's probably around the fact that they're not actually recording them very well, and that's part of the reason why they're judged inadequate, because they don't have adequate systems for reporting. The other things, so falls that result in fractures and pressure ulcers, are not particularly related to CQC inspection judgments, and again that makes sense because those sorts of things are probably going to be more related to resident characteristics. They are related to care, but the most important thing here is probably around the resident characteristics rather than the other things that are going on in the home in terms of risk factors. Just to give you some quick descriptive view of what the homes look like, this part of the graph is showing you sort of the skills mix of the homes on average. So around about, on average, 80% of care hours per month being provided by care assistants, and then around about 15% by senior care assistants and around about 28% by nurses, and you can see the sort of there's variation around that you can see within the bars. Of the quality-related incidents, apart from falls, which, as I said, aren't really that closely related to quality, these things are all quite rare. Most common are medication errors, but even those, they don't happen very often, although there's quite a long tail. Pressure ulcers don't happen very often. Falls that result in fractures don't happen very often. Complaints happen slightly more often. But these are generally quite rare incidents. So, what we're interested in doing is, can we predict what is associated with those types of quality-related incidents? So our models are able to accurately predict CQC inspection judgments 98% of the time. And the things that predict CQC inspection judgments in comparison with the skills for care data isn't really related to do with staffing. It's more about the percentage of residents with nursing needs, the percentage of residents with dementia, and the percentage of residents who are self-funded. Staffing comes in a little bit, but it's probably in quite a descriptive way rather than the causal way. So outstanding homes have more senior care assistant hours and fewer nursing hours. Again, we've already seen that nursing homes or homes with nursing find it harder to get higher scores and are more at risk of getting lower scores. So that's not probably a causal thing going on there. It's just that, you know, running nursing homes is more complex. There are more things going wrong, or that can go wrong, and the CQC therefore take a kind of slightly stricter line with them. Key things on this slide, you can't make this out, but I'll just run through the most important parts. Essentially, this is saying that we see a similar picture with other measures of quality. We're able to predict with a high degree of accuracy when these things happen and the things that are going to be associated with it. Perhaps reassuringly, pressure ulcers doesn't show up on this graph because we only found it after we submitted this graph to NIHR for clearance. But the most predictive thing of pressure ulcers is whether a home has end-of-life care or not, which is in a way quite reassuring because it suggests to us that it's probably the end-of-life residents who are more at risk of pressure ulcers. And if you think about the challenges of caring for someone with end-of-life care, they've probably got multiple things wrong with them. There might be difficulties because of those things that are wrong with them in moving them, and there are trade-offs to be made between preventing pressure ulcers and allowing them to sort of live the last few days with dignity and as much comfort as they can. With falls, dementia is the most important predictor, again, as you might expect. When we look at falls with fractures, self-funded residents are explanatory here. Again, if we think that self-funded residents are probably more likely to be mobile because they've got less acute care needs than residents who are funded by CQC or local authority. So that could be part of that story. You see more falls with fractures where you sort of related to nursing, and I'll unpick that in a minute. Medication errors, interestingly, more occupied beds, more medication errors. So when you're busy, you're more likely to make a mistake, intuitively. Complaints, you get more complaints with self-funded residents. Complaints are also related to nursing, and I'll unpick that again in a minute. So I'm going to show you some of our very preliminary results now. This is really to give you a flavour of what we're doing. These results may change as we refine our analysis in a kind of iterative process of going back to the care home operator, sharing our results with them, getting their feedback on whether we think that they think we're kind of representing things accurately. They are suggesting things to us that we could add to the modelling to improve the accuracy, and that's going to change these results, but this gives you a flavour. Again, this is just to show you the relationship between the proportion of senior care workers who work in a home and the risk of there being a fall in a month. And what you see here is as the proportion of care hours taken by senior care assistants increases, risk of fall falls, but only up to a point. And then past that point, it's not really related to the number of falls that we see. And again, if we think about why that is, what you're seeing in homes with higher numbers of senior care assistants, typically more dementia residents, larger homes, residents with more acute needs. So up to a point, having more senior care assistants makes a difference, but only up to a point. This is the relationship between nursing hours and falls with fractures, and it's quite a noisy graph. We've already kind of improved the specification here a bit in a graph I can't show you because we haven't cleared it with IHR. So the same sort of picture is emerging. Essentially, as nursing hours increase, the risk of falls with fractures reduces. But, and again, this is about what I was saying about the problems of working with observational data earlier. What our results suggest is you need a really big increase in nursing hours to really reduce the risk of falls. Okay, so in an average home with about 50 residents, if you increased nursing hours from 142 per month to 426 a month, you'd on average reduce the number of falls from about 3.5 per year to about 1 per year, or falls with fractures to 1 per year. So that's quite a big investment in nursing for quite a small reduction in fractures. And if we were thinking about what's a cost-effective intervention, that probably wouldn't be it. But at the same time, if you think about that for a minute, if you had all that extra nursing hours, nurses would probably be doing different things to what they're doing at the moment. So we can't necessarily extrapolate from the observational data that we see to what would actually happen if we had more nursing hours, if we're able to pay for and recruit that many extra nursing hours, which of course would be a massive challenge. Again, this is the relation between nursing hours and the CQC scores and medication errors. So again, this shows as nursing hours increase, your risk of medication errors falls, but only up to a point. And this shows that where you have a higher CQC well-led score, you've got less risk of medication errors. The interesting thing about the CQC score of medication errors is what direction is the causality travelling in? Are CQC inspectors going into homes, looking at medication errors and taking a low number of medication errors as a sign that this is a good home and therefore giving it a higher score? Or is it genuinely kind of causal? It's a kind of interesting question. Be interested in what you think about that. Final results slide, I think. This is the relation between nursing and CQC well-led score and complaints. Again, what you see is when you have more nursing hours, you have fewer complaints. So carers and residents themselves certainly seem to have less cause for complaint when you have more nursing hours. Similar picture with CQC well-led scores. Final thing I want to talk about, how am I doing for time? Right, really quickly then. We were interested in labour market conditions, okay, because talking to care home operators, one of the big challenges when you've got a low-paid workforce, how do you retain that workforce? How do you stop them going for other jobs that might be a bit higher paid somewhere else? So we thought it might be a bit easier in places with higher levels of unemployment and lower wages more generally. So what we did is we took a load of labour market data. We looked at lots of different ways of modelling it, but the way we settled on, we used cluster analysis, and we clustered local authorities into 3 different types of labour market. There's 4 here, but the 4th is essentially central London. One, which is green, which is higher wages, lower unemployment, more jobs, more skills and more qualified workers. Red, lower wages, lower unemployment, higher unemployment, less employment and less qualified workers, and amber's in the middle. This map gives you an idea of how that pans out. So green, the home counties, some other pockets of the country, essentially high wages, low unemployment, high employment. Red is rural areas, so Lincolnshire, North Norfolk, Mid Wales, but also post-industrial areas, so the South Wales valleys, South Yorkshire, North Nottinghamshire, places like that. Okay, and this is just very preliminary, but what we found was in the red areas, it's harder to get a good CQC rating or a better CQC rating. You're more at risk of getting a lower CQC rating. This is an area where we want to do more research because local authority is quite a big area, and most homes seem to have quite local labour markets. One care home operator we talked to said that most of their staff walked to work. So we want to close in the geographical area around the home to get a more accurate picture. Because this was counterintuitive, we talked to the care home operator about it, and they said particularly in those rural areas it can be really hard to recruit and retain care home managers. So that might be something that's going on there as well, and we're going to go back and try to get more detailed measures of care home manager into the data to try and find that. So, overall conclusion, provisional conclusions. If we look at skills for care data, we can predict CQC inspection score based on staffing. But when we put that together with the care home operator data, it's probably not the staffing that's the causal factor there. What we found is evidence that when you have a more skilled, more experienced care home workforce, you tend to get higher quality on the measures of quality that we have measures for. But we're not sure how causal that is. And when we try and do some simulations to think about, well, what would we need to do in terms of the workforce to improve quality, you sort of get these huge numbers of nursing hours to really improve things. And this is one of the problems of working with observational data. So to relate this back to the idea of the learning healthcare system that I started with, I think something we're learning from this is the limitations of observational data. I think this is quite an exciting and promising line of research, but it's not necessarily going to tell us this is how to run care homes optimally based on what we see them doing, but it does give us a basis for perhaps doing experiments where we say, actually we think if we did this differently, this might improve this. Well, what we could then do is work with the care home operator to say, well, why don't you try it in some of your homes but not others, and then we can use this type of data to model the effect of that intervention. But the observational data on its own is probably not enough. I'll stop now. Thank you.
Okay, loads of food for thought from Andy and from Kirsty, and not all of it intuitive. So at this point, I'm going to let you just draw breath for a second and hand over to Sir Alan Langlands, who is going to use his wealth of experience to navigate us through the next period of time and introduce the panel as well, and we'll have more discussion. So thank you very much.
Okay, thank you, and thank you for two excellent talks, which we maybe get a chance to come back to as the evening goes on. But the first thing to do is to get this very impressive panel up here so that I can introduce them and give them their opportunity to respond and make their contribution to the evening. So.
There's microphones here if you want to use them.
It's okay. Okay, well, welcome panel, and I haven't met all of the panel, and some of you who were here earlier will note that I came in late, but I'm going to try and guess who they are. So, okay, so the first one's very easy, and it's my opportunity to welcome Martin Green, who's the Chief Executive of Care England. Is that right? Indeed. Yep. And I'm guessing that the next person is Shona McFarlane, who's the Deputy Director of for Social Care Services and Social Work at Leeds City Council. Is that right? Yes. Yeah, good, thank you. And next is Councillor Rebecca Charwood, the Executive Member in Leeds City Council for Health, Wellbeing and Adults. Good. Now this is where I'm going to slightly struggle. I think second from the end, wearing pink, is Vivian Birch. And Vivian Birch is the Director of Quality and Compliance at Bupa Care Services. Welcome. Oh, sorry, did I get that wrong? Oh, I did. Okay. Well, why don't you introduce yourselves at the end of the table, because I've confused the last two people. I'm terribly sorry.
I'm Val Hughes, the Chief Executive Care at Leeds. And I'm Ruth Holton, Director of Nursing and Care Sector Lead for NHS England.
Okay, what a panel. So they have the toughest job of the night, because they've got to make their contribution before we open up to wider discussion in 3 minutes. Not, I suspect, in any particular order. I think it would be cruel to pick them randomly. So I'm going to go in the order I'm given and ask Martin to kick off.
Thank you very much, Sir Alan. And I will try and be brief. I'm going to pull out what I consider to be some clear messages for various bits of the system, and then also throw out what I think is the challenge for the next phase of the research. I want to also particularly thank the University of Leeds and Bupa for doing this research, because I think the presentation at the start showed what an extremely complex area this is, and the need to try and establish how we deliver quality care effectively and efficiently is really, really important. And I think we need to have three very distinct measures. One is the person experience. Is the person who is receiving care getting a good experience? The second are the outcomes that are achieved by the service. And the third is the effectiveness and the efficiency of how we use resources. Now, I think there are some really clear messages for everyone in the system from this research, the interim findings of this research. The first thing I think is really important is that it shows people who are care workers just how important their role is, and that every interaction they have with a person they are supporting is going to be a definer of whether or not there's a quality experience there. So I think it really shows people that it's a complex job, but you have the power to make a difference if you're a practitioner. I think we also have got some really good, clear messages for care providers. I think it really shows the necessary skills mix that are required. I think it shows that there are some ratios that are needed in order to deliver high quality care. There are some really important messages from this research about how care providers enable their staff to support each other, to become part of teams, to reflect on practice, and to make sure that they have a sort of continuous improvement approach. I think that also will link into the role of commissioners and how they see good quality services and make sure that they commission for outcomes and for quality rather than always on price. And I think that's very challenging and very difficult, because I don't underestimate the challenges of trying to do that in a very constrained system. I think also the interim findings show the importance of training and development. My personal view is we've got to start training people for a career pathway, and we've got to also integrate the training of health and social care so that we see people being trained for outcomes rather than for specific roles. And I think that was shown by the skills mix data, how important that is, and getting that right. I think there's a role for regulators as well to be able to be more predictive about how services will show quality. And I think that's going to be really important, because we need to be much more data driven in the way in which we regulate services. And the reason we need to do that is we have to have much more consistency. My final challenge is about how we both combine the data that we've got out of these interim research results into having a really clear view about what's necessary to deliver quality. But I also want to make a plea for some qualitative data which enables people to understand this is a person-to-person sector, and some of the definitions of quality will be defined by the service user. So the example I want to use is that I fly regularly, and I never fly British Airways, not because the planes crash, but it's because the service is dreadful. And I always fly Emirates because the service is fantastic. Now, if you look at the parameters of quality, both those airlines are working to the same level of quality. Both those airlines are assuring me that their planes won't crash, but the experience of me as a customer is enormously different. And so one of the things that we must recognise in this agenda around quality is that it's the experience of the person using the service who is also important. So a lot of the data we've seen in these interim findings tells us what we need to do to create the foundations of quality. But we need to move beyond that to say what are the interactions that enable people to feel that they've had a quality experience and to ensure that their well-being has been developed and assured. So those are the areas that I think the next phase of the research needs to focus on. Thank you, Sarah.
Okay, thank you very much. And next on my list is Ruth. Ruth?
One at the table to the other. Thank you.
Yes, indeed.
Yeah, I do actually. Thank you.
So I'm a terrible mumbler, so I will use the microphone. Is that okay? Yeah. Thank you. Thank you for those presentations. They were fantastic. And a really clear explanation. I love the forest bit and the Christmas trees. I've made some notes on that one, and I should pinch that and take it away with me. That was really helpful. I guess a couple of things first. The research itself, I think, Karen, when you introduced it, you were talking in terms of older people. I think it's really important that we remember that care homes aren't just for older people. There's a really important group within the care home sector who are providing care for people with learning difficulties, mental health, and a variety of other physical, neurological conditions. And I'd really like to see them represented within the study if it's possible to do that, so we get that broad brush. I was also surprised to hear there'd been no studies of this kind, and it's refreshing to know that there's a new area to go into by way of research, but also huge parallels, I think, with the research that already exists within hospital and NHS settings. And a challenge to you as researchers, we hear a lot about the NHS, less about social care research, and that's certainly something that Leeds University and your partners are trying to change. But can we start pushing some of this back into the NHS and telling them about quality from a different angle and from a different viewpoint? There's a lot we could do there. And certainly your definition involving residents, relatives and staff, I think is a very broad definition, and that's really helpful to us. Within this, there was something about people and how we get the right environment for people to deliver the best care possible. And we talked about having skills, having the opportunity and feeling motivated. I wonder whether you're going to unpack any of that and really tell us what motivation is about and how we motivate people within the sector. I personally, in my job, meet all sorts of people, usually in outstanding care homes, but they're absolutely fizzing with what they're doing in a good care home, and you can really kind of feel it, and it's tangible, but I don't know how you describe it in a way that you could say to somebody else, this is a really motivated, really engaged member of staff, and I'd like to see that. The other thing I would say in terms of looking at what's going on in the environment, the market oversight, I think there's some opportunities to link with some of the work that particularly ADAS is doing, looking into markets and looking into the local populations and demographics, and I can certainly connect you with some really good pieces of work that are happening there that would be useful. And finally, I think for me, if you're going to look at further questions, I'd like to know about what makes a good leader in the care sector, and particularly in care homes, and whether some of your research will help us with that. And also, what contributes to the stability of a workforce. Because again, you can go from one care home to another. They'll be in very similar geographical areas, and in one it'll be a story of woe and how staff are leaving rapidly, and in another they'll say, I've been here 15 years, I've worked 20 years, I've been here a long time. So something about what contributes to the stability of the workforce. I don't know, where's the microphone going next?
The microphone is going to Councillor Charwood.
Thank you very much. Thank you very much for having me here. It's really good to listen to the research and be here with you all. Thank you for that. I am the Cabinet Member for Social Care in the Leeds City Council, but I also chair the Health and Wellbeing Board for Leeds, which is the health and care system for the city. And we do try to solve complex problems around care and social sort of flow in the system and things like that, workforce, in a system way now. And I think that works really well. I can see many colleagues here actually today. I just came from Scrutiny Board, and that's where they scrutinise us, other councils scrutinise me and Shona and others about our performance in keeping quality in the city and care homes. So it's really good to see the university focusing on care. It's really under exposed, if you like. People don't look at it enough, so I'm really pleased that you are. We know from our experience that nursing care is more difficult to have high quality in. It's in the city, that's certainly the case, and it's usually medication errors and record keeping, the areas that fall down, and it's not surprising to see that coming through in the research as well. We've got great links with the university through the Academic Health Partnership. The part of that is to try to get the research that you do into Leeds residents' lives and make a difference to our people. So again, I'm really pleased to be able to use this research there. Because we commission obviously quite a lot and have big budgets around it, but we also have a market shaping role, which I'm sure Shona might go into. So one thing I did think about when you were doing the research, explaining the research to us, was about innovative approaches to registration models. So historically, the nursing care assistant workforce jobs have been quite traditional and had one did medication and those sorts of things. I think actually the CQC a few years ago did a registration review where they looked at opening up those sorts of models. I wonder if you might just augment it a bit with, like, if there are some interesting models out there, it might not be enough to do sort of data research on, but you might be able to shine a light on actually when you have a different skill mix and you have different roles, people perhaps doing nursing tasks that aren't nurses, and how does that work and does it look any different? Because actually the funding is a really big issue. Sustainability of nursing care is a huge issue for providers, and that can obviously probably affect quality. Funding is really a big topic, I suppose, with the social care green paper. We still don't have any certainty about that, and funding comes from many sources: local authorities, CCGs, self-funders. But I thought it was a really interesting piece of research. Lovely to hear that small teams have greater reciprocity. I was really warmed by that, and that leaders create a shared sense of purpose. That's a really lovely thing for me to take away as well.
Okay, thank you. And Shona.
Thank you. Again, lovely to be here this evening, an absolute pleasure to be amongst the audience and also the academics in the room. I just wanted to start by saying it's really good to see that the research has included people and their families as part of it. That the relationship with people is the fundamental element of a good quality service of any description, and the research involving them is really important to hear people's voices embedded into this work. In some ways, some of the research wasn't a surprise in many respects. It kind of underpins some of the knowledge and the years of just knowing things that comes from working in the field. We know that smaller homes do tend to be more effective, better quality. My particular bias, if you like, is the quality of the manager. I've followed homes as they've, I call them roller coaster homes, as they go from one element of CQC registration through to another. And what always defines that is the quality of the manager. The manager is to me, the defining element of quality in a care home. In Leeds, we've recognised that. We've got a quality team, and we're also investing in a leadership academy for registered managers, because we think that's a really important part of having a good quality service. And I think that was recognised in the research, but it may also be an area to do further research into the qualities of those managers, the good managers. I liked, as has been said, the conversation about reciprocity. I think developing teams that are self-sustaining, that are able to work in a way that they've got permission to work to bring all of the skill that they have to the table, I think is another challenge, and good managers manage to do that. Back onto my bias. I'm really pleased to see research in this area as well, because I think it has already been said, there's an awful lot of research into healthcare. There's much less done into the fields of social care provision, and so I really welcome that. So thank you.
Okay, thank you. And Vivian?
Hello everyone. So I have been working closely, or reasonably close, with Karen and Andy on this topic, and it's a really important piece of work for us. I think a lot of you in the room who are associated with care homes will know the challenges that we face in recruiting and retaining good quality staff. So this is really helpful for us to understand, well, what does it take to really drive our quality? So I think the work on reciprocity, I had not heard of that, and I'm not going to be able to say it properly now, reciprocity, whatever. Yes. I found that really interesting. I've not heard of that term before, but actually giving people permission to get involved with resident care, and creating some space so that staff can talk about residents. So in Bupa we do have various meetings, handover meetings, and we call them Take 10. But I think there's probably something a little bit more than that, some sort of huddles that you can do with smaller groups of staff around residents and be really person-centred. So I found that really quite interesting. I could see that would really motivate our people. We recognise in Bupa that in order to deliver really great person-centred care, our people need to love working with our residents, and they will thrive if we create that environment for them. So I thought that was really a really interesting piece. But I think, I think to hear that larger homes, nursing homes, dementia homes have poorer outcomes, that's really something that we need to face into. So what does it take in terms of our staffing models to make sure that our residents in nursing dementia homes and the larger homes do have really good quality outcomes, and that we do hear the voice of the resident? So I think that's a particular challenge. So to recruit nurses, to recruit really good people who are experienced in dementia care is a challenge. So is there a role, I suppose going into what Rebecca was talking about, is there a role somewhere between the nurse and the carer? And we are working on this in Bupa. We call that role a care practitioner. It's just evolving. But I would really like to see, as we work with Leeds on this piece of work, which we've still got a period of time to go through, that we can look at that role of care practitioner, and is that delivering really good outcomes for residents? So what is the skill mix? What type of skill will drive really good care? But I think it isn't just about skill, and I think it comes back to that reciprocity. It's giving staff permission and time to talk about the resident, And lastly, but you can't ignore it, 'cause we know through experience in Bupa, the leader is absolutely pivotal. So to have a really strong home manager, and as Shona was saying, we've had a few services that have come up and down, and they come back up again and they stay up when you've got a really strong leader who creates that environment of reciprocity within the home. But I think what we really need to tackle now is what is the skill, what is that role between nursing and carer that can really help drive good quality care in care homes.
Okay, thank you. And finally, Val.
Thank you. It gives me massive pleasure from a carers organisation to be invited here to actually have it recognised just how important and valuable the role of the family carer is in driving quality in care homes. It wouldn't come as a surprise to you to hear that for me, most of the work that we do is about supporting families as the person they've been caring for in many cases, many years, makes that move into a care home. And we continue to support those people afterwards and the families as well. Because the one thing which was so important here, and I think it's been spoken about, is that leadership within the home, that real stability of the team. Because the people who come to us are often the ones who are upset that they don't see the same person, they don't see the same manager, there's different messages being passed, and that all leads to a real sense of confusion, frustration, fear and anxiety in families. And if this going forward, one of the challenges would be is to really see how we can involve the family carer who for many cases have cared for a long time and are the experts in that person's care to really drive up the quality. So to actually have them as part of the partnership between the care home, the care workers and also the resident and the families as well. Because, as you mentioned before, what is vital in all of this is the personal experience. This was fascinating to me. Because the second part, that kind of real, the bit there about falls and pressures, I was just thinking that so many of our families come back and tell us that those are the things they see as quality. If somebody has got pressure sores, if they've had falls, if they've been in the home and fell within the first week and gone into hospital. So it really is, for me, very much about how homes make people feel. And I think that's the culture in a home. And culture in a home comes very much from the permissions for staff to get to know people and to get to know the families as well. Because I really believe they are going into that setting, the actual experts in the care. So I would really like, I think that what was an important finding is about that leadership and about the stability of the team, which I think is really important, then the culture and the importance of the values in there. So where do those values come from? I think it comes from the leader and the stability of the team. And I would like to say what was maybe missing and what I'd like to see going forward is the importance of the involvement of families and carers and the vital role that they have to play in supporting their family members, both in the decisions made about them and for them, and that settling in period as well. Because I think if we get that right, then we'll drive up the quality. Things will actually work out in a much better way longer term if we actually invest that time at the very beginning of that transition. I also think there's something really important about changing our language and busting myths about nursing homes and care homes. And I think certainly in my work we've got a real responsibility to do that as well. Because for the well-being of the person, that's what it's about. It's about those interactions as well. So I would love to see that work going forward really involving families and carers and in that partnership work to actually say how we can make those interactions meaningful as well. But this was great for me to be involved because I'm obviously going to say how important it is for the success, for the way a person and a family is made to feel in a care home. Those initial weeks of that, you don't get those weeks back. It really is important to make that part right for the success for the resident and their well-being.
Okay, thank you very much. Thank you very much indeed. We can open it out now. Remember that Karen and Kirsty and Andy are still in the room, and I don't think we want to turn this into a question and answer session for them, but they are here and they can supplement what they said as part of the discussion. So we're really looking for points that you would like to make in support of this work or to challenge it, and the opportunity to pick up anything that the panel members have said that resonates particularly with you or with which you disagree. So open house. Yes, right in the middle here, middle of the. Maybe just say quickly who you are.
Yeah, I'm Nick Garrett. I work for the Whole Systems Partnership. I've spent some time in local government at Leeds and North Yorkshire County Councils. I just wondered if it was worth looking in the research, particularly at reciprocity, about the role of digital technology in care home staffing and that effect it can have on quality. Maybe its role in either fostering reciprocity or even working against it. If that was something that was picked up by research or has already been noted, that would be interesting.
Okay. I was going to say we might collect some questions, but I think that one's complicated enough to take it on its own. Any
response to that?
Carol, you want?
Yeah, I mean, it's not a direct focus for this project, but one of the things we learned today is that actually the university's just literally today been awarded a grant to look at the unintended consequences of computerised decision support. One of the sectors we'll be looking at is care homes. On the grounds from the NHRHS&DR programme, on the grounds that actually it doesn't always work in the way that we think it's going to work. It's not always positive. So the answer to that is it's not a direct focus for this particular project, although it may come out in the quantitative findings, but it's definitely going to be a focus starting from September for about 18 months, looking at the unintended consequences of that in this sector.
Anyone from the panel want to pick up this point?
Well, I think we've got to start thinking more creatively about how we use digital and other technological support, because I was talking to Shona earlier and I was delighted to hear that Leeds are going to do some work on how technology can improve the experience of the resident and also free up staff to be having more time doing resident-to-resident work. So I think there's going to be a big role for technology, and the challenge will be to identify what is the technological support that will enable staff to be able to be more connected to residents.
And not use the saved time for technology for efficiency to map up against staff savings.
But actually the other thing to say though is, you look at Carol Jagger's research from Newcastle and the numbers of people that are going to be needing 24-hour care. We are not going to be able to sustain current models without getting more creative and innovative. So I think technology will have a role to play, but as long as it's technology that enables people to be more independent and staff to be more person-focused, I think it can be very important.
Ruth, did you want to come in? No?
Thank you. In terms of the NHS England programme for the coming year, digital tech is actually very high on our agenda. So some opportunities, I think, to think about how we use that to best effect. Because Martin's right, we could put bucket loads of technology into care homes, but it doesn't necessarily change the life of the people who live there, either as residents or working there. But I am increasingly seeing different bits of tech in care homes when I go and visit them. And I think for me, there's something about how we can join some of this up, because we are in danger of having lots of very independent systems, which might be right, but would get the benefit from the connection. And I saw a fantastic piece of work this morning in a trust where they've brought health and social care teams together into one place, and they're accessing the same health records. And I think to be able to do that is just such a huge step forward, but it takes some creative and bigger thinking, I think, to get that started. But huge opportunities, and we keep coming back to where Martin started from. What do we need for the resident and for the staff to free up their time to deliver more or better care? I think we'll get the right systems.
Thank you. So just on the system issue, because I'm always trying to think, I'm always thinking about the system of health and care rather than individual components of it. So quite often the problem with care homes in the system is that they're individual business owners, they're not particularly part of one big system, so the flow between them and out of them can be, and how to get things moving and to keep people there is a challenge. So we've got telehealth. It's telehealth, isn't it? The way you call it, where residents can perhaps stay in the care home for longer rather than going to hospital when they have a condition that the staff are perhaps nervous about. Whereas traditionally they might get sent to hospital and they'd be like, or even just that disruptive. They can do a Skype type consultation with the hospital. I think it's Airedale, there you go. So that, you know, it's innovative approaches like that which might keep people well in a care home. I'm not sure how it would relate to quality scores, but surely that sort of thing is all for the good.
Okay, thank you very much. Yes, Paul.
So Paul Stewart, the Dean for Medicine and Health. I'll shout. Oh, there you go, it's on. So I really enjoyed this as well. Just a kind of macro issue, if I may, before I come on to the point, and that's to just reiterate where Rebecca was coming from on this. You know, this whole interface between the flow of patients between secondary and social care is a big issue for every large city, and you know, NHS Digital produce these data almost on a weekly basis of where we are in Leeds. And you know, thanks to the alignment and join-up across sectors, there's been huge progress on this with, you know, Newton Europe work and a real head of steam. And that's so important because, as we know, patients that are in this transition have an outcome that's actually worse than many patients with terminal cancer. It's a health issue we have to grapple. And what's been really rewarding for me is seeing you know, Karen come to Leeds Clinical Senate, and the whole energy in this space is enforced by this, exactly what we're hearing today. So congratulations to all. The specific point I wanted to make was just, again, on the technology one, is much of what we've heard tonight is, and I'm aware of this, is going to be confounded by different status of different patients. And there is a way, again, using technology of standardising that through the frailty index, which was invented by a Leeds academic working with the elderly care czar in Bradford, actually. That is now a System 1 platform. And it might just be worthwhile thinking if you can have something in there that, if you like, it is a validation, if you like, just of some of the issues you were talking about. You know, patients who might have more comorbidities and be you know, much more compromised than others, and that might be a nice validation bit. And the final thing was just to reiterate where Martin's coming from. It would be great if some of this was qualitative and, you know, even patient carer feedback. If we can get, even in a small sample size, get any data on that, would be really helpful. Yeah.
Okay, thank you. Any other points around the room? Yes, right at the back.
Hello, I'm Nadia Yena. I work for Bupa Care Services. It's lovely to hear about it's coming out that you need a well-trained workforce, knowledgeable and skilled, to have a person-centred approach and good leadership and consistent leadership. But one of my questions was, when you were looking at the quality indicators, I was wondering how quality of life was going to be defined. And I was really happy to hear that residents and relatives have been involved in the working parties, but were their views on what they saw as being quality of life taken into account when looking at the different data sets, and maybe seeing how that can be analysed? Because I think that could be something that would feed into what the panel have said about analysing the data of what's positive for the residents and their families. Certainly links in with what Val was saying and what Viv was saying. It's like, it's the service users, it's the residents, it's people's experiences, isn't it, that's really important. And that's a really high quality driver. When CQC visit, they will ask them, what's it like for you? And that's part of what they will look at when they're making their judgments on the services that they're inspecting.
Thank you. Anyone want to come back on these points? I think most people are agreeing with you. But
it is. I think the whole thing about the quality of life of the person and the family is just so vital, and it's that thing again about what might be quality of life for one person may not be for somebody else, and it's just how we actually are able to speak to people about what it is that's important to them. And for some people it's just, it actually doesn't matter what the place looks like as long as I've got people who I know care for my relative and listen to what I'm saying and kind of ask me and make me part of that. That's quality of life for a family and for the person as well. And it's, I just completely agree with what you're saying about that and what it is, and ask the question of what it makes people feel and how it is in that home. Because for most people it is about feeling safe, feeling secure, being asked about their opinions, not being done to, but being done for, all of those things which are vital. And people lose that when they go into care homes. People tend to do things for people, and it's kind of, it's your time to rest, but it's not. It's about how we actually work together so people don't lose skills as well. So that again is something else that people talk about quality of life about as well. So people don't kind of just give up when they go into a care home, but that they're encouraged to be themselves, to find out who those people are, who their families are. And that's, again, when I go back to the culture of the place and giving people permission to have time to do those things.
Okay, thank you very much. Yes, Karen.
I wonder if it, can you hear me all right? I'm from Newcastle. I think it's probably a good point to say that one of the next work packages we're about to start is actually to do the thing a lot of you are asking for, which is
thank you, Rena. The qualitative aspect of this, so an opportunity to speak with residents, their relatives, care home staff, care home managers, also staff who are delivering services in care homes about their perspectives of what quality is. So we will be gathering that interview data. We're also going to be spending time observing some of the subtle things that are going on in homes, which we think actually that's really key for influencing quality. We'll be looking at things like documents, where resident and relative meetings are document what kind of issues are coming up, how do they get resolved. So through these approaches, we hope to gather that sort of depth of understanding to try and address quality from all these different angles. So it's been brought up a few times, so I thought I just wanted to reassure you that that's actually one of the next work packages that we are going to be doing.
Okay, thank you. Yes, Rebecca.
Just on that, I think it'd be interesting if you can and if it's possible to look at the relationship between quality and transitions, just from picking up that point about do people get transferred in and out a lot, and that might be something you can look at from a data point of view and ask questions about that, whether it's a good thing or a bad thing.
Okay, thank you. We've got 2 or 3 minutes of time for a few questions. Yes, right here. And then we've got one at the back and one over here, and that's probably going to do it. Yeah.
Thank you very much, Janet Hurst, School of Healthcare. So I'm very, very pleased to hear about the research, because I have quite an ordinary knowledge about care homes, so I've probably got a social ideology about what a care home is isn't. And this research is going to create a body of knowledge. And one of the things I've heard about from the panel is revolving door in terms of leadership. And if you want leadership and stability, it almost needs professionalising what a career in a care home may be, regardless of the role in that sector. So this is really pleasing that we can create a body of knowledge to create a profession to attract our students. Because one of the things I am aware of, talking to some of our nursing students, the attractiveness of care homes of a career is few and far between, because we haven't got that professional recognition, which the start of the body of knowledge would give. And I just wondered if you had a view about how quickly that could be fast-tracked, because sure as eggs needs to be quicker, because it's an ideal opportunity for students' experiences, for a revolving door, if we're having a one leads approach to the workforce, so people going into care homes, coming out of care homes into other sector of caring for people, be it older people, be it people with mental health needs. I just wondered if there was a trajectory going forward.
I'll hold that question, and we'll take one more at the back and then come back to the panel.
Sorry, I'm Joe Croft. You have to bear with me, my voice isn't the best. I work for Bupa in a national role. I was interested when I looked at the slide around the demographics to questionnaire, because a lot of that is about quantitative data. And when we're talking about qualitative data and quality of life, is the work going to be done across a national basis, or are we going to be localising that? Because we need the qualitative data across a national area to be able to understand that the different cultures around the different areas.
Okay, Karen, I'm going to come to the panel on Janet's questions, and then to question, and then to you on that last question.
It's not necessarily a Leeds-based answer, but I'm just probably going to respond in terms of how we're approaching it in Bupa. So, as I mentioned earlier, finding really good quality managers and retaining really good quality leaders is a real challenge for us. But what we are currently doing is looking at our clinical workforce and looking at career pathways for nurses. So we're really keen to engage with students or those that come into the end of their nursing career, because actually care home is a fantastic opportunity for nurses, both in terms of either a management pathway through operational management and managing a care home, or through a clinical pathway leading clinical care, and looking at how we can drive quality. So actually for our clinical leaders coming in, we're creating a pathway at the moment for preceptorship nurses. How do we support nurses that are just starting their career? How do we support nurses to become clinical services managers, being the clinical leader in the home? And actually we do have some managers of care homes that are not clinical. So we're going out of sector as well to try and find really good leaders. So to run a care home, it's good if you're a clinician as well, but actually sometimes that's a really hard, difficult person to find. But you can find really good leaders, operational managers with a good clinical support would do really well as a leader. So it's not Pan Leeds answer, but it's really top of our list of activity in terms of how do we recruit managers and how do we retain them by then giving them other career opportunities within Bupa beyond even care home management.
Okay, well, yes, okay.
Can I just follow up with a quick comment? Just in terms of social care and the image, if I talk to anybody in social care who's practising in either a care home or home care, one of the first things they say to me is we've got to get over this image that social care has. And I think we all have a responsibility in the room to share some of the really good things that are going on. I mean, yes, the sector has problems, but then so does the NHS and so does every other area of work and area of care. I think it's a real responsibility for us to share some of the positives and to get that across. I guess back to you, Janet, my thing would be about getting students into care homes and into home care. I think the richness of that experience is huge, and whether people decide to make that a career or not, to have had that experience and then to move through their career and be able to draw on direct experience of well-delivered care within the sector, I think is massive, and it will really help the residents who receive the care, but also that image and that recruitment and all the other things that go with it. So really a request to the university, if you haven't got students in care homes and home care, then please do think about it.
Okay, Martin Moss.
Yeah, I just want to reiterate that, and in fact we developed something called the Teaching Care Homes programme, because I'd like to see syllabuses requiring nurses, doctors to do time in care homes staff to do time in hospitals. I also want to remind people that the NHS spends £100,000 a minute on training, and none of that is available to social care. And yet we are told by the Department of Health that we have a Department of Health and social care and an integrated system. Well, clearly we don't. I think, Janet, it was relatively easy to fix, but it requires a massive cultural and structural change, and it requires syllabuses to be different, but it requires money to flow across systems to meet people's needs rather than to meet the needs of organisations.
Okay, Karen, a quick sentence on the spread of this project.
Answer, yes, it's national.
The homes that we'll sample for the qualitative study will be across England, and we'll pick them based on what kind of quality scores the homes have. So we want to go into mixes of homes, different types of homes, so homes with nursing care and residential environments, the size of the home as well. So we're taking these factors into consideration when we sample, but yes, it is national. It won't just be within the Leeds area.
Okay, thank you very much. And one last question right in the middle.
Richard Graham, I'm the care quality team manager in Leeds City Council, and it's been good to see people beginning to recognise leaders and managers, because I don't think a lot of people actually understand how difficult it is to be a registered manager. And I think what you've got to do with the registered manager is you've got the skills, you've got the knowledge and their experience. But, and having listened to the research, it makes a huge amount of sense to me and everything links together. But what I'm really interested in, and it's probably going to be almost impossible, is I am interested in the personality of the registered manager. I can tell you very quickly who will be a good registered manager and who will not. I couldn't put that down into a series of kind of lists or anything. I used to be a registered manager. I've got all the skills, all the knowledge, all the ability. I couldn't be a registered manager now because I don't have the personality, those personal skills and ability. And there's something about, is there any possibility of looking at the personality of good managers? Because I think that is a really key aspect. And there are lots of questionnaires and things out there. I think you would find a really clear link, but I'd love to see the research to prove or disprove me about the personality and that person themselves. You just know when a person is going to be a good manager and when they're not. And it is about their personality. And I think that would, a lot of the kind of the data that we've seen could be linked back to that, who the good manager is. And I really can't understand why anybody would want to be a registered manager.
Okay, well, thank you very much. I'm afraid it's time to draw to a halt, but I think there are refreshments outside and therefore the opportunity to pick things up with members of the panel and indeed the earlier speakers. I don't want to bang on, but because most of you are very kind of expert in this area, so my expertise really, recent expertise runs to the last 90 minutes, but just one or two reflections from me. One of points that have come out really strongly. One, I think, is for me just the sheer size and complexity of the sector and the issues you're dealing with, and the likelihood that that not only is going to become larger as time goes on, but is also going to be more complex. So complex in terms of the age range of the people who have been looked after, the complex needs of each individual, both social, the relationship with family being hugely important, but also, drawing on Paul's point, the fact that these people are often ill with a whole range of different diseases interacting, the jargon of comorbidities. And when I was thinking about that when you were talking about medicine errors, I'm just kind of envisaging what a difficult job that is to do. I think this relationship between the quality of life and the quality of care is a kind of very powerful idea, but a difficult one to get at. And I do think, even compared to the NHS with all its scale, you do have a great diversity and flexibility in the workforce, which you don't often see in other parts of the community. So acknowledging, firstly, that this is a difficult issue, and I think a difficult issue to study. It also has this kind of, CQC got lots of mentions tonight, it also has this very kind of interesting and increasingly intrusive system of regulation and assessment overlaying it, and that cannot be easy to answer. The researchers themselves, impossible to summarise, but just pick out one or two key points. I think right up front, Kirsty made this important point about the importance of context, and also I think this very kind of nice relationship she described in terms of knowledge and skills, in which she included a caring nature. So how do you assess that? But also brought to my mind the sense of the self-confidence that people must have in this sector, given that the problems they're faced with day to day, and the sort of decisions they have to make. I also think, I mean, almost on its own, the whole question of team size, team dynamics, and team reciprocity is a kind of study in itself, but a very interesting one indeed, and a very good angle on this. Coming to Andy, there is a great seductive thing going on at the moment where people suggest that data and data analytics are some sort of panacea that are going to solve all our problems. And I think his kind of real-world approach to this was hugely refreshing. I mean, having said that, for my mind, he did make some very strong provisional conclusions, and some of the linkages and the associations he was able to draw out in discussion, very powerful and certainly worth pursuing. But he did also warn us several times about causation. I think this is a sector which could, in very rapid time, become overwhelmed with data, especially if we start doing what previously has been the impossible of linking in a more considered way health and social care data on a kind of regular basis. Obviously it's going to happen, but we're going to need people like Andy around to stop us leaping to great conclusions. So great talks, but like all good research talks, throwing up questions, and you've thrown up more questions for the team to pursue. Final thing I wanted to alight on was this, with two points really, just to reinforce them right at the end. One was the significance of management and leadership. I used to, many years ago, be able to say I only had to be in a hospital for less than 60 seconds to know how well it was being managed. And I think the same is probably true in your sector. But being able to articulate that and enable that and ensure kind of good practice on a very large scale is a really difficult thing to do. And finally, just to kind of reinforce Val's point about the expectations of families, and particularly the way in which family members and often spouses feel at the point of transition. I mean, I know I've kind of experienced this in my own life, and it's one of the most difficult things to do. And the people who are working in care homes on a day-to-day basis can make that so much better for all of us. And I think in the main do, but it does seem like a very crucial issue. The final thing I want to do is to say thank you. I want to thank Bupa. I want to thank NIHR, the Health Services Delivery Research Programme, in this case Health and Social Services Delivery Research Programme, but they are important supporters, not just for this, but for many things that go on. And also, particular thank you to all members of the panel who've come along, taken part tonight, and contributed. And I wonder if you might just give them a quick round of applause. My final thank you is to Karen, Kirsty and Andy, and I wonder if you could give them a round of applause. And finally, can I thank all of you? From here you look quite daunting, but you've been a great audience with great questions, and that's much appreciated. So thank you.